and a very warm welcome to the Nomad Dog Healthcare Stories podcast. We've got a wonderful episode for you today. We'll be talking all things stroke, and I've got some amazing guests, so I'm going to let them introduce themselves. So we've got Dr. Paul Bolaji, and we've got Prof. Benjamin Dozier on the call. And we would ask Dr. Paul Bolaji to kindly introduce himself and tell us about the work you're doing in the stroke space.
Hello, good afternoon. Thank you so much. Also, hi B, for a great podcast. So I'm Paul Bolaji. I'm a stroke consultant and I'm based in the United Kingdom.
Okay, thank you. And over to you, Prof.
Hey, good afternoon, everybody. My name is Professor Benjamin Dozier. I'm a professor of clinical medicine and neurology. My earliest days in neurology started in the United States almost about 2 decades ago, where I trained in general neurology and further did fellowships at the Thomas Jefferson University in stroke, they call vascular neurology and neurocritical care. For over a decade and a half, I was a stroke consultant and chairman of neurosciences and stroke service in Novant Health in North Carolina. It's called Forsyth Medical Center. But about 7 years ago, I pivoted and decided that it was time for me to go back to Nigeria. And I've been in Nigeria now for about 6 years plus. I run a privately owned stroke facilities called Regions Healthcare, Regions Stroke and Neurosciences, under Regions Healthcare Hospital and Specialist Clinic. So we've been going now for the past 6 years here in Nigeria. So I would say I'm lucky to have both intercontinental views of stroke care, both in the United States where I trained and worked, and here in Nigeria. Thank you for having me.
Yeah, thank you very much for coming on board.
Oh.
Okay, so are you able to tell us a little bit about what is the current state of a typical Nigerian patient pathway if they've been identified to have a stroke? So from the symptom onset to hospital arrival, what is currently happening for someone who presents with a stroke? Probably, Prof, you may want to answer that.
Well, that's a very interesting and intriguing question. So for you to better understand what is going on in Nigeria, you need to understand what is expected. In developed countries, at least in the United States where I worked, I'm sure in Europe and UK as well, if you have a stroke, no matter where you have a stroke, the first thing you activate is the EMS. So the EMS comes, they represent what we call pre-hospital care. You're appropriately transported to a stroke center or a stroke-ready hospital. During this transport, the EMS typically are trained to be able to perform some basic neurological examinations specific for stroke patients, trying to help to identify if this is really a stroke or not. From the pre-hospital care, you get to a hospital that is a stroke-ready minimum, or a stroke hospital, or even a comprehensive stroke center where you're evaluated in the emergency department. On arrival in the emergency department, the stroke service is typically activated. The stroke team come, led in most cases by a stroke neurologist. They evaluate you and they do their examination, trying to figure out the severity of the stroke, the side of the stroke, and they order imaging very quickly. There's a time window for you to do this. In most hospitals in the US, it used to be 1 hour, but then went down to 30 minutes. And in some cases, we can get this done in 10 to 15 minutes. What I'm trying to do this time is to find out what type of stroke are we dealing with and what interventions the patient is going to receive. In most cases, if you qualify within the time window, typically 4.5 hours from onset, you get a drug we call tissue plasminogen. That is basically a clot buster that dissolves the clot that causes the type of the subset of stroke we call ischemic stroke, which outnumbers most strokes that we receive in hospitals worldwide. There are basically two types of stroke: the bleeding, non-bleeding. The non-bleeding is the ischemic stroke. So they get you the TPA. Why they're doing that? They're looking at the further images, which you would have obtained in most cases, a multimodality imaging, including the CT scan of the brain, the vasculature, and perfusion studies looking at the functional state of the brain. And at the end of that process, they determine whether you have what we call a large vessel occlusion, and therefore you may qualify to get a thrombectomy, which basically is going inside the brain and pulling the clot out, because we know that quite a few of those clots cannot be dissolved by that clot buster called TPA. And then following that, whether you got only TPA or you didn't get TPA, in some situations you might not get that, or you got a thrombectomy, then you're transported to the ICU for at least the first 24 hours, especially if you got TPA or thrombectomy, because they are quite intensive nursing care that takes place and physician evaluation. And then after 24 hours, you're evaluated and sent to the stroke ward. And then the rest continues from there. Unfortunately, in Nigeria, it's not the case. It's nearly not the case. And I've been doing this for the past 6 years, trying to raise awareness in a private space, in a private facility. And still, it's not the same, even for people in private hospitals, let alone people in public hospitals. So the Nigerian patient's journey often, sadly, in most cases, starts with expressing the symptoms, not even understanding that those symptoms are stroke. And even sometimes when they do understand, the majority of people tell them, well, it's spiritual. So that those are some of the underlying problems we have here. All sorts of myths around stroke. The devil has slapped you, or they ignore the symptoms, or they first get to the church, or they get to the primary care doctors who may or may not recognize what's going on. There are barely any designated stroke center in Nigeria. Designated. And I'm not saying that there are not hospitals that treat strokes. There are quite a few teaching hospitals that have people who are very smart, who work hard every day to save stroke patients and try to put them in the pathway I described earlier. So in most cases, pre-hospital care and emergency transport is non-existent, because the patient would probably arrive in their private car, private vehicle, therefore wasting a lot of valuable time. So in a lot of cases, they are not a stroke team to immediately activate. The people who get to see you in the emergency rooms, even in some of the public hospitals, will be the general emergency room doctors. They will evaluate you. And of course, as you know, in a lot of cases, these hospitals do not have an imaging center inside the hospitals, like a CT scan, MRI. So that's another process. They have to transport you out to the diagnostic centers to get those studies done. And in a lot of cases, clotbuster TPA is not available. So you don't even get to get it. And even if it's available, we're looking at a 4.5-hour window to deliver that TPA, although that could be extended based on some recent studies and information we have received about how the brain works. And then even at that, the imaging required for that is sort of complex functional images, perfusion studies that are not easy to read by a lot of the radiologists or a lot of people around. And then only very recently did we start at all doing thrombectomy. That is that clot retrieval using endovascular surgery in Nigeria. And I'm happy to be one of the people who pioneered that. It's run by a doctor who trained in the United States, a radiologist, interventional radiologist who had to learn the art here in Nigeria, and Dr. Nina Lowo. But because a radiologist needs a neurologist and needs a stroke doctor, so we run a telemedicine, telestroke service called Region Stroke Alert. So we support him 24/7. And he's been able to do quite a few of those thrombectomies. So, but we're talking about one center in Lagos that is able to do that with a consortium of doctors. So this is typically the journey of a stroke patient in Nigeria compared to what you see in developed countries. Although a lot of, hopefully we'll touch about a lot of work is being done. And I want to thank my good friend Paul Balaji, who has been very aggressive in pushing this. You know, I came back to Nigeria, tried to push it. And because I didn't train in Nigeria at all, I didn't know the right steps to take. Bolaji, it's very different from me in the sense he trained in Nigeria, I believe, before he went to the UK, so he knows the right buttons to press. And he's been doing a lot to making sure that we move the hand of the clock towards giving patients proper care.
I think you mentioned so many things there that I would love to explore a bit more. But one question I would love to ask, which I think a lot of people would wonder, is if somebody had a stroke today, let's use Lagos as the example because that's where some of the services are. If someone had a stroke today, where would you recommend in the public system that a patient can go to and they would be able to access most of the things that you talked about?
I don't know about the public system a lot because I didn't train in Nigeria. And let me just comment that a lot of the people in the public sectors are very, very smart people, very, very hardworking. They want to make a change. But the question is, do they have the resources all the time to be able? Because for you to be a stroke radio, a stroke hospital, you have to be ready 24/7 to be able to offer this 365 days a year to be able to offer this. So I don't know a lot about the public hospital. I do know about the private facilities because they call me. There's also some interesting things, a private-based doctor being able to offer help or service or advice in public hospitals, which is a discussion for another day. So, Paul, where would you recommend that? Do you know in Lagos?
Thank you so much, Prof, for your initial answers and also IB. Yeah, I think from a public space in Lagos, obviously we have the two, key also teaching hospitals in Lagos. We have the Lutz and we have the Lasut too, which and I think also there's a general hospital in Lagos too, which has a capacity to offer good stroke care. But particularly in Lasut, also they do have a very a dedicated stroke unit. So Lasut is that place, and Lutz in the public sector that you can have a stroke unit care. The problems always in the public space is obviously a lot of bureaucracies in accessing care. And I think, when you go to the emergency department, from experience, and I did work in the UCH even before I moved to UK. And even before you get care, you need to register, you need to pay for, and that's enough time. And as Prof. Aya has clearly said, stroke is time. So I think the bureaucracies in stroke care in those public hospitals will delay stroke care. I think there was a very important, interesting research done by Professor Bole, who was one of the neuroradiologists, that the average time people get stroke treatments was around 24 hours. So I think there's a whole lot of delays with regards to that. But in terms of availability, Luton and Lasut have a very good stroke also unit care, and I do work with a lot of them. Professor Ogun, who is one of the neurologists in Lasut, and Lutz also Professor Okubadejo, and a lot of great neurologists there. But as I've explained, the bureaucracies is a big problem.
So that kind of pivots to the question of, as you said, brain is time. There's the delay on the patient side in recognizing the symptoms in themselves. Then there's the bureaucracy, as you describe it, in getting access to care once they've arrived at the hospital where they need to be looked after. So you published a paper on the capacity across, the African continent. And one of the quoted things there is that only 10% of patients have access to thrombectomy. Is there any hospital in the public system in Nigeria that has access to thrombectomy for stroke care, as far as you are able to tell?
Yeah, okay, thank you so much, Heidi. I think the 10% is actually for thrombolysis.
Oh, right, okay. I stand corrected.
It's thrombolysis. To the best of my knowledge, in terms of what the definition of a comprehensive stroke center is, we don't have a comprehensive stroke center, where you have an acute stroke care plus a thrombectomy service in the same building. We don't have it in Nigeria. Obviously, there's been some pockets of thrombectomies, from radiologists. Dr. Nina Olowo has done some thrombectomies back in Lagos. But in terms of having a dedicated comprehensive stroke center, I know in regions is one of the best, obviously private, also tertiary neuroscience facility. I know they have ability to network with other hospitals for thrombectomy. But from what I know, there's no comprehensive stroke center. There's no dedicated center for thrombectomy in Nigeria. So thrombolysis, even 10% is being too very gracious. I think our thrombolysis rate is far less than 10%. I spoke with a lot of my colleagues, even in Abuja, where you have a federal capital territory. I spoke with one of my colleagues who said he has not thrombolized for the last 2 years in Abuja teaching hospital. And one of the problem is because people don't actually arrive on time, and so even stocking those medications is a big problem. Also because they are not being used regularly, and even the people who are going to require it needs to pay significantly out of pocket. From what I know even tenecteplase could be like 2 million naira per bar. I don't know how much it is. It is expensive. So even thrombolysis, there's a big problem, let alone thrombectomy.
Okay, so essentially, this is a national emergency because, in terms of non-communicable diseases, after cancer and heart disease, stroke is the next number one killer for most, from most countries, and in particular in Nigeria. So the treatments that we have for stroke is, when we're talking about ischemic stroke, is either thrombolysis or thrombectomy. And what we're hearing is there is no national thrombectomy service in the public healthcare system in Nigeria. There is something happening in the private healthcare space, but mainly based in Lagos at the moment, as Prof alluded to. And in terms of thrombolysis, there is limitation in terms of access to the drugs and access to the people who can actually deliver the medication and the treatment safely. So there is a national crisis without mincing words. So how do we address this issue from a systemic perspective? I mean, I'm going to ask this question to yourself, Prof, because you're on ground in Nigeria. If you were advising, the Lagos State Health Minister or the Health Minister for Nigeria, how do they need to approach this and manage this problem?
Sure. Very good question. And I've been here to live it, from delivering some of the best stroke care around the world in the United States in our comprehensive stroke center. We had a comprehensive stroke center. And by the way, what Paul was trying to say, a comprehensive stroke center is a hospital that can provide a continuum of care from the EMS side, emergency room side, offering the thrombolysis and doing the thrombectomies, ICU care, and send it to rehab. That was what he was describing. Let me just correct one notion there, though. I can tell you emphatically that FCC in Lagos, Ikoyi Lagos, can offer that care 24/7, 365 days. And FCC have been able to do that because we provide through our region's stroke alert tele-stroke service round the clock. And I work with some of the best people around the world, by the way, who pick up that phone at any point in time when those patients arrive. Tele-stroke service has been shown to have been able to bridge the gap between having the neurologist at bedside and offering care in stroke, and this being validated. So we use that for them. Dr. Nilowo, 90% of the time is in town, barely travels to the United States. And when he does, he's trained a fellow, Dr. Denigba, and also Yemi Johnson, who's an interventional cardiologist who can be able to offer that service. So from the problem, of course, they can't do the EMS side, but once you arrive, I can assure you, you get that initial evaluation, get that drug in, do the CT angiogram, do the perfusion studies, take you into the angio suite and put the clot out. And like Paul said, we also have that capacity, and that's where capacity is involved. And I'm going to come back to that in trying to give you an answer to what you asked in terms of how will I advise the health minister. So we have an angio suite in regions, where we give thrombolysis, but who is going to run that angio suite? So I have a guy who comes from the US. He comes every 3 months, spends 2 weeks, he goes back. That's not stroke thrombectomy as far as I'm concerned. He does one case, he disappears, he comes back again. So capacity is one of our problems. We don't just have the capacity. And because a lot of our decisions in Nigeria for the professionals is influenced by the economic metrics in Nigeria. So when you're telling somebody you're just a freshly minted radiologist or neurologist or neurosurgeon, you're saying, come, let me send you to another place to do training for another 2 years. Meanwhile, they're looking at it and their family is telling them, well, this is the time for you to start making money. How are they going to do that? So they're not interested in doing that. And in most cases, of course, when they go, they don't come back for obvious reasons, economic push factors as well. Beyond capacity, which I've just stressed here, is equipment. Invest a lot of money in getting an MRI in your system, getting the appropriate MRI that can do those diffusion studies and perfusion studies, getting a CT scan in your system that can also do run, and then getting other things that may not be that expensive, including ultrasonography they use for your carotid duplex studies. We are regions who have invested a lot of money in that. So we have 2 CT scans. We have a 32-slice CT that does the CT angiography and perfusion study. We just acquired a 160-slice CT that does that. We have a 1.5 Tesla MRI to do that for stroke patients and other things. And let me tell you, it's not because I love to spend money, but I can't practice without those things. That's how I was trained. And I'll tell you, the folks who trained me in the US were very, very worried when I said I was going back to Nigeria. I said, how are you going to practice? Because that's how I trained. I have to see it before I act. We had to invest that money. We had to do a lot of training for our local doctors. And because a lot of them wouldn't understand why you do the NIH scale, why the time is important. In our hospital, we had to train them, and we keep training them, the nurses, to do swallow evaluation and plenty of things that have to be done. So we've talked about manpower. We've talked about not just having the doctors, but the appropriately trained doctors who are willing to be trained both in basic and advanced skill sets. We talked about the equipment, but it's not. Sometimes you have the equipment like you were discussing earlier on, and there's nobody to run it. And when we came down here to Owerri, there were about 3 CT scanners here in Owerri. But if you did a scan on Friday, you get the result of the scan on Monday. How does that happen? And it's a stroke patient. And then we started pushing, because we didn't have our own that time, for them to do scans in the night for us. We eventually had an understanding with a diagnostic center to do it for us. But it was like pulling a tooth. You beg and plead in the course of the night. Now we've breached that, and now tell you FCC can do that as well round the clock. So training the radiographer, training the nurses. So training is also another big issue. Now, as Paul said, the drug is 2 million naira. People don't understand it. Even sometimes our colleagues in our field, but definitely people who are in primary care providers, you're telling the first thing you get asked is how much is the drug? We say 2 million naira. But they don't even recommend it for their patient. And I tell them, recommend it for your patient. Let them make the decision to say yes or no. You just talked about being the number 3 killer, non-communicable disease, but also number 1 cause of disability, and the fact that stroke in our environment tend to affect the people who are in the workforce. The young people, 40s and 60s, we die. A lot of us die because of our life expectancy before we get to 60s, based on WHO records. But anyways, so we lose those core manpower people. We don't even understand what it's doing in our economy. So cost, you don't blame people. How much does the average person have to feed the family, let alone buying one single drug for 2 million naira? And we're not talking about hospital stays. So the government, or whoever I'm advising, I would say, do what other African countries like Kenya have done, Tanzania have done. Have some sort of program that provides these drugs to the patients. Understand that this is killing your people, and something got to be done. Stroke fatality in Nigeria is so astronomical that it's so shameful. The first 7 days, about 28% of them die. In the first 30 days, about 40% of them die. And when you talk about this, people say, oh, well, they survived. Well, what are the statistics? What are the numbers? Look at the numbers. Not because John and Stephen and Mary survived. What of the other ones we are not talking about? And we're talking about people who showed up in the hospital, not people who did it. So we need to have a national program to make TPA available to patients. Yeah, the penetrance and the acceptability may be low. I was in the US in the early days of I was in training, and I remember as a young resident, you call the attendants, the consultant in the night, that there's a patient who needed TPA. They will find a way to tell you all the things to be able to wriggle out of it, because they were scared about the bleeding, until we now found out that the bleeding risk, which was supposed to be about 5.6%, wasn't that high. And even with the new drug drug we call tenacious places, probably about 2 to 3%. And if you choose your patients well, you probably will have 0%. So I will talk about that. I would say have a program, and you might not necessarily cover everybody. Give UCH 20 TPAs in a year. At least 20 people get it for free in UCH. Give some of these hospitals. You can't save everybody, but start something. Maybe 100 vials. Distribute 1,000 or 10,000 vials across the country. So it's not costing you so much. Start something. Look at the impact. Look at what the difference is making in people's lives, and then scale it up. Look for donors. To be able to support these things. Encourage manufacturing, drug manufacturing companies to come to Africa, to come to Nigeria to produce these things. Tenacious places produce the ones we use here, produced in India, so the price is pretty cheap. The more people use these things, the less it's going to cost. With regards to diagnostics, figure out a way to partner with private entities. I tried something here before we acquired our own images, and what I did was I went around some of the diagnostics, and there were probably about 3, 4 then, and I said, listen, give me a deal. Anytime a patient comes with a stroke, they can come to you, get the imaging done. We can assess them through telemedicine in your place, and we can keep the drug in your place, and then at least push the drug while they now come to us. Like Bolaji said, most of those drugs expired on them. So, well, we lost. I have about 40 vials of TPA that I just bought. We just bought about 3 months ago. We have not given one out. So there's not even a public awareness. Come to where we spend probably about 10 million naira in billboards, talking to people about stroke and putting all these billboards. We approach the government. We try to say, can you work with us? Let's raise this awareness, maybe get us some free billboards. We'll print the thing to put on it. So the government has to take stroke care seriously. Thrombolysis, thrombectomy, good things to do for stroke patients, but there are still some little things that can make a huge difference. Identifying that this is stroke, knowing what not to do and what to do for hemorrhagic and ischemic stroke, crashing their blood pressure down in that initial time for ischemic stroke patients. This thing does a lot of harm. I'll tell you, we had a paper we presented at the Association of African Strokers Organization in Kenya a few months ago in our center. And we discovered that most of the patients who were coming to us from outside hospital were dying or coming in with aspiration pneumonia. Teaching health extenders and nurses to do a simple bedside swallow evaluation, just get pure water, put it in a spoon, give it to the patient. If they cough or clear their throat, don't feed them. Our people are big on feeding. If you're sick, the next thing that's stuffing, what you call pap down your throat is going to the lungs, that developing aspiration pneumonia. Starting things like aspirin, early aspirin, evaluating for them for lipid profile. These basic things have to be in place. Yeah, we're talking about the big, expensive things, but can we just start with the basic things? You heard Bolaji talk about stroke units, creating stroke units in a lot of these places. And it's easy to create. It just has to do with having a protocol in place, and giving stroke patients access to getting this care. And finally, I will say to them, understand that the personnel may not be a big problem, but we have the Bolajis. There are lots of people like him, out there. There are people like me who can come together and provide this service through telemedicine for like peanuts. The patient shows up in Lut or shows up somewhere, and we don't have the big Professor Gun and Wakumbadajo in those places. We can offer that care, and this has been shown to work. In fact, we recently published a paper with what we're doing with FCC in Lagos to show that this has been shown to deliver stroke service, even though we are offering this remotely, and people do accept it. I mean, I took care of a stroke patient we're currently still, who arrived on FCC. His family got on us on WhatsApp, and we spoke to them. We have a special application for telestroke, but we did that with that, and then the family, and then we spoke to them, talked to them. So they accepted it because they realized that what we were telling them could be verified. And of course, they were asking their relatives. So those are some of the simple things I would advise government to start.
And thank you for talking about that. I think stroke is one of those conditions where you don't just need one specialist. It highlights the need for cohesion in the system where you have a proper MDT that's looking after that patient. As you said, it's not just the neuroradiologist who's able to do the thrombectomy. You need the nurses who are able to provide good bedside care. So if the patient is not mobile, all the bedside care of turning the patient, make sure they don't get bed sores, simple things like that, so that actually prolongs the health of a patient. So I think my next question is going to be one of the things you touched on, like if a patient turns up to a particular place and they can't afford the simple, basic, acute stroke care, what would you advise, clinicians looking after these patients to do? Because if you can't give thrombolysis and you can't give thrombectomy to a patient who comes in with an ischemic stroke, how else can they look after this patient to make sure? I mean, you've touched on it before in terms of MDT management, but what else can they do to at least provide some secondary prevention for that patient?
I tell people one thing. If your patient has 50,000 naira, maybe 60,000 naira to spend if they've had a stroke, please spend it on an imaging study. Look into the brain. Because once you look into the brain, you're able to figure out the type of stroke. Is it bleeding stroke? Is it non-bleeding stroke? The moment you figure that out, the pathway for treatment is diverges. For instance, the non-bleeding, the ischemic, you want their blood pressure to ride high for the first 3 days or even beyond to allow brain perfusion. The bleeding stroke, you can moderately reduce their blood pressure and their guidelines for that. The non-bleeding stroke, you have to start them antiplatelet agent or immediately. The bleeding stroke, you want to delay that for a few days depending on what's going on. That imaging is a lot of cases also will show you the pattern of the stroke. Is it what we call cardioembolic? If you have several showers, is it a large vessel, small vessel disease? It kind of gives you that, so it forms the basis. Then I would say to you, once you've done that imaging, have a good nursing care, bedside nursing, swallow evaluation at the bedside. If they cough, if they clear their throat, just put an NG tube. The NG tube is very cheap, and then feed them. Yeah, they may look ugly, and the family wants you to pull it out and all of that, but you're saving the patient, decreasing the length of stay in the hospital, and they're saving them the pain of buying big, expensive antibiotics and also debt. Then I would say to you, if it's an ischemic stroke, particularly, then and they're immobilized, start them on DVT prophylaxis. Clexane is cheap in Nigeria. The TED stockings they put on, there's nothing to show that it works. I wouldn't suggest that. But if you can't get any of those things, how does the sequential compressive device work? It just gives you sequential massaging of the calf muscle. So get their family members to, from time to time, keep massaging their calf muscle. That is free of charge. And if they have a little money to spend, then I'll spend a little bit on figuring out the etiology of the stroke. I'll do an echocardiogram, most cases about 40,000 naira. Just look at their heart, and then early mobilization. Work with a rehab team. If you have a rehab team, they can't afford it, then work with the family. There are many videos out there on YouTube they can watch. It's free. And then families suddenly become the occupational therapists and the physical therapists that can walk these people around. Early mobilization, you have to do it. Teach your nurses how to do this. Basic things. Once the patient gets better, probably when they have the money, they need to now do the secondary stroke workup. But I believe that all patients should get appropriate secondary stroke workup, because you have to understand what caused the stroke and know how to limit that. If you have a dietitian, they counsel them and look at their blood sugar, A1C if possible. They'll counsel them on their dietary modification. Even little things like that can make a lot of difference if they don't have the big money to buy statin therapy and those kinds of things. But sometimes they do. And food modifications that can help reduce cholesterol and improve blood sugar, and weight loss is a big thing. I will tell you from my personal experience, about a year ago, my A1C was 7.8, and I didn't tell anybody because I was this big. And my lipids were off the roof. I didn't want to tell anybody, but at that time, I dieted, I exercised. And my A1C is 5.0 now. My lipids have all come down to normal, and I'm using myself as a testimony. So there are things you can do that can reduce distance without you having to spend all that money. I used to be on 2 blood pressure medications. I'm not on any now. So I take my aspirin, which is very cheap, but these things are very cheap. So yes, that would be my advice.
Yeah, I think thank you so much, Prof. Anya. I think you've gone through the entire stroke pathway from pre-hospital care to prevention to the stroke unit care to rehabilitation within just also 5 minutes. And really, I just want to say once again also thank you for your service. All the way from the US, you came to establish a comprehensive neuroscience center in Nigeria. You're one of our heroes, I would say. So, what I just wanted to chip in is that we do have overwhelming evidence from the works from Peter Langon, who did a lot of studies and trials on stroke units, that also patients who are managed in a dedicated stroke unit are likely to be independent, are likely to survive, and are likely to be discharged home. Compared to if they are managed in a general ward. So even without the acute reperfusion therapy, stroke unit, a dedicated stroke unit, as Professor Ayawa said, with good nursing care, with a very good also pathway, you have processes, you know what to do if this patient fails to swallow. You have a dedicated structure. You have trained doctors who are able to spot also signs of complications of stroke and manage them. You have a good pathway for secondary prevention, and you've got a good MDT with rehabilitation physiotherapy. So if you've got a dedicated stroke unit, we do have evidence that that's enough, would improve the quality of care, even without having the acute reperfusion therapy.
Thank you, Paul. The hospitals we work with in Lagos, we provide telestroke service. The first thing we did was we handed them our stroke pathway. That's the first thing we did. And we said, you must follow this pathway all the time. That's the first thing. Just this is our stroke pathway. So what Paul said is very important, that a lot of these hospitals need to have a stroke pathway and just consistently follow that. That way, Paul comes in the morning, he does what I'm going to do the next day, and John does the same thing, and everybody does the same thing. Makes life so easy. In fact, you don't have to think. I tell my junior doctors here, I say, just follow the pathway. Please don't think. Just follow it. Tick, 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 follow it. That on its own, if we have some sort of a national pathway, universally accepted, that people will consistently follow. Now, the other comment I would say is stroke units, like he said, makes a lot of difference. But even in the United States, we flex our beds. So we flex our bed. Even in regions, we flex our bed. What does it mean? We know that this is a stroke unit. We know what comprises the stroke unit, but the infrastructure, the telemetry, and all of that, if you have that, which is important, the MDTs that round together. But yes, bed 1 may be a stroke unit. But that doesn't mean if I have a head trauma and I don't have a stroke patient, I can't put a patient there. Then I move the patient to bed 2. The most important thing is that there is a dedicated team, a multidisciplinary team that meets all the time, rounds together which is what we do in our place, round together every day. This is not where you say, I'm the doctor, you're the nurse. And where our dietitians, they run with us, our nurses run with us, our physiotherapists, both occupational therapy, physical therapy run with us, the doctors run with us, the nurses run with us. And that's how we do it. And then once every week, we sit down in a room, and then we'll go, Mr. John, 75-year-old, with this, we discuss all of that, everybody contributes. And that's how it's done. And you do that, you start seeing fantastic results. Because keep in mind, and I'm telling you from personal experience, 1 in 4 of us will have a stroke in our lifetime, and you don't know who it is. I'm telling you from a personal experience. I can assure you that statement that 1 in 4 of us is going to have a stroke in our lifetime, you don't know who it is. And for Nigeria, you will not have that time to get on a flight and zoom off to go get care abroad. And we've seen that with a lot of people with national prominence die of stroke over the years. Of course, when they die, the next thing after a brief illness, well, that's probably what caused that death.
Yeah. And I think we should probably say that you should not get on a plane if you've just had a stroke straight away. You're putting yourself at risk if you do that. Yeah. So we've talked about so much, and I think, one of the things that you kind of alluded to at the end there was about governance. And in the governance of human capital is training and protocols, and in the system itself is getting the system to work the way it's meant to work, whether it's in terms of equipment, in terms of having the right staff, in terms of having the right units and capacity to do neurocritical care. The question is, what financial reforms do we need in the system so that we can create those acute stroke units? Is this something where that the National Health Insurance Scheme is able to provide for this? Or as you mentioned earlier, we need public-private partnerships to make it work. It sounds like we've kind of got something working in Lagos. How do we get that to spread across the country where we know that there is a similar first cardiology hospital in Maiduguri somewhere that can provide the same kind of care that is happening in Lagos? What should the government do about that in terms of financing that and making that a reality, going from policy, frameworks, conversations to actual reality on ground to make that happen?
So I'll tell you some basics. One, you have to understand how the civil service structure works in Nigeria. It took me a while to understand this. If people are becoming stroke nurses, but they're not recognized in the public service, in the health sector as a stroke nurse, they would not do that. Period. So nephrology is recognized. You can be a nephrology nurse, and it means that in the civil service, you're recognized specialty nurse. There's nothing like that in stroke for now. So we organize a stroke nurses symposium. Why are you coming? It doesn't help you. So that's number one. The same thing with even the stroke doctors. We, in the US, and I believe in Europe as well, stroke is a subspecialty of its own. I did my residency in general neurology, but I had to go back and do fellowships in stroke to become a subspecialist. So I think there's some works going on. I don't know how far, but like you may know, in trying to create stroke fellowships so that those doctors get that designation. Everything in Nigeria is about paper, certificate, and that's driven because of the way the civil service structure works. So that has to happen. The other thing that has to happen is, we've talked about infrastructure. Some of these things are so expensive, but the stroke units. So if you have the appropriate nurses who work in those places, we have a neurorehabilitation team, for instance. So it's not just the nurses, but also the rehab people have to be recognized to be specialists in stroke or neuro. So again, it's a public service something. And if you just do this little thing that I just talked about, you will see that you encourage. There are many smart people who are doing a lot of work. It's not just Bolaji and I. In fact, we are doing nothing compared to the many, many other physicians here in Nigeria. And he mentioned some names that are doing a lot of work, neurologists that are actually scratching and doing a lot more work than us. I'm sorry to say that I live in luxury because I have most of the things I work with. Fortunately, because I have those things, and it makes care very expensive because we have to buy those things. With our money, and we need to figure out a way to pay for the loans you use to buy those things. You get money from the government, upwards of $1 billion plus to buy a good MRI. Of course, you're going to get your money back too, because you have to pay the government and the bank back. Same thing with CT scans and all of these things. But yes, those little structural changes within the civil service is going to make a lot of difference. Promotion, national, the country take it serious that stroke is a problem, and be able to provide health education or small funding to tell people, no, this is stroke, and this can be treated. Because there are like doctors in this country that tell stroke patients, why are you going to a hospital? Go to the herbalist. That's where you treat stroke. Just that raising that national awareness is going to make a lot of patients flood to hospitals and then receive this basic care. And we're talking about basic care, and then from there you grow from there. So the country has to be able to promote some of these public education around stroke through radio advertisements and through billboards or whatever it is, whichever way, just like they do for tuberculosis, just like they do for smoking, just like they do for measles, because it's going to make a lot of difference in people accepting that this is what's not need to be done. Again, I've focused more in very basic things. And I think from my experience, once you start these basic things, you're going to see people asking more questions, like you're asking us questions too. Can you imagine if we have 1,000 people ask this question you just asked within a month? It would change the paradigm of care in Nigeria. So if you have like 5 million people, we know about 200,000, 250,000 strokes occur in this country every year. It's a lot more the ones who show up in the hospital. So if you have 50,000 people asking this question every year, in the next 5 years, the landscape will completely change. I mean, we're talking about TPA. In the US, I remember in the early days, like I said, doctors didn't want to give it, and until it became a serious litigious issue. And then you started seeing people, when they come into the emergency room, they say, I want that drug, I want that clot buster. Well, if the patient is saying, I want the clot buster, and you're the junior resident or junior attendant, who are you not to give it to them when they're already telling you, when they're demanding that? So if we figure out a way to help people demand for quality care, the paradigm changes.
I agree with you, definitely. And I do think improving stroke care in Nigeria, it's a collective approach. As you've said, we need the stroke organization. It's a privilege for me to be part of the African Stroke Organization, which also Professor Ayan Wutsu is a member. We also have a Nigerian Stroke Organization. Last year, we organized the Nigerian Stroke Leaders Summit, the first one. And one of the plans is for us to actually develop a stroke working groups, where would actually target 4 aspects of stroke care: stroke prevention and awareness, stroke services, stroke research, and stroke education. And the plan is for us to convey the more than 200 people that registered, to actually meet a forum where we divide them into those working groups and see if we can bring out a national stroke action plan. That is a vision. I'm still trying to talk with Professor Kemi and so on. So I do think as national stroke organizations, we need to work hand in hand with the government. It's very important. Even beyond the national health insurance coverage, the fact that we need to lobby so that we make sure that the national health insurance also cover the full stroke also pathway, from the CT scan even to the rehab. We need to make sure we do that. I think we should have a dedicated national stroke funding, specifically that any stroke patient, wherever you may be, your stroke care is sorted. Stroke is an emergency. Even in developing countries like India and so on, it's free. Access is free. I think it is unfair to somebody who has had a stroke not to be treated well. So if, as much as possible, we can allow the National Health Insurance Fund to cover the stroke pathway. But beyond that, the stroke also charities, stroke support organization, the National Stroke Organization, we need to work hand in hand with the government to create a national stroke fund to support people with stroke. And I think that will go a long way. And as Professor Ayawa said, is that anybody can have stroke anytime. So if we want to develop a good system that would also cater for every one of us, no matter how rich or poor you are, we need to create a standard system. I remember what happened in Anthony Joshua, because obviously there was no ambulance services. So no matter who you are, if we don't have a system with a very good stroke care, it will affect you. And that's why it is imperative for us, as National Stroke Organization, African Stroke Organization, we need to start working with the government. We need to work in hand with them to shape the policies and to make sure that stroke care is funded. And I think that is where we can start.
But Paul, let me just add one idea I have. Sometimes when you have this big, huge elephant project, the government looks at the bills, they don't want to pay for it. You know what I'm saying? Because it's a lot. So what about phased care? So she talked about the national health insurance. National health insurance can do some basic things for stroke patients. Pay for their CT scan. They can. They used to. I don't know if they still do that. Simple. Pay for their aspirin. Pay for their basic antihypertensive medication, the basic ones. Figure out a statin that is cheap. There are quite a lot of them that are cheap, and flood them and pay for their statin. Train the nurses to do bedside evaluation for swallowing. These things, these 5 things, it won't cost them arm and leg. We're not talking about thrombolytics now. Figure out a way to create programs that people can watch at their home and how to do rehab for their people. Do this for the first 5 years. Look at how far we've come. And just keep adding one more thing to it. If we don't do it this way, we're going to keep having this discussion in the next 20 years. Yeah. But if we start small so that the budget is not so much, just a small thing, and then they can incrementally increase that budget by 10% every year. So you will see, once we start doing that, you're going to see a remarkable difference in about 5 years. But if we are packing everything together and tell them you're doing everything, they won't do it. And if government officials are listening to me, I think we need to start thinking about it. This can be you. Because I had a close shave myself. I'm a stroke doctor. I do the right thing for myself. And the thing that saved me was that about a year ago, I had decided to save my lifestyle. I was tired of the pot belly and the big face and the chopping well. And I began to exercise. I began to lose weight. I began to eat right. I began to do the right things for myself. And boom, it struck. But I'm here talking because I had started those things way before I had that event. So if it can happen to me, the stroke specialist, without any family history, by the way, it can happen to you. And we all need to do something about it. Think about it. You have no time to get on that flight. And telling your sir, ma, let's do something about it.
Okay. So, and that's a national rallying call, I think, for our system. I want to just ask a few questions and then we'll just conclude this conversation. How can pre-hospital systems and ambulance networks, how can they be strengthened for stroke emergencies? Because we talked a lot about the in-hospital care. And I looked into this because I was like, what if we had, the same kind of system some countries have, where you have a mobile stroke unit? What would it cost to have one of those? And, the figure that came up was $2 million to actually get just one of those. So already the capital investment for that is high. But with the current, ambulance system that we have, let's again use Lagos as an example. What can be done to strengthen that? You talked about telemedicine, for example. How can that be fed into the emergency network system to help deliver this care at the point of contact with patients?
After Paul mentioned about Anthony Joshua, we have ambulance services in regions, but we didn't take it very serious. We had like 2 ambulances. But after that Anthony Joshua thing, I said to my team, guys, we have to invest money on dedicated stroke ambulance. And we went out and bought that. And we have that now. And more recently, we also have invested some money to buy. And I'm talking about a proper ambulance, not what Nigerians call ambulance. I'm talking about a proper ambulance that has the multimodality monitoring. And in both of them, we also have transport ventilators, a proper ambulance, not Toyota Sienna or whatever, and there's oxygen on the floor. We're talking about proper ambulance. So recently we also had to do that for cardiac. I think that if I were to advise the government, I don't think government can do it alone. Things cost money. Let's be realistic. What I would do if I were government is to rally people like regions, and there are many regions around the country that have specifications on those ambulances, and then have a network of ambulances. I mean, there are a lot of private hospitals and public hospitals, plus government in Lagos, for instance, that have proper ambulances. Rally all of them, have it, tally all of them, create a network, a proper telephone system, not just owned by the government. So if you sign up, you're part of it. That works. That when somebody needs a stroke ambulance, they make that call. Somebody picks it. The first person to pick it, transports the patient. Also have some kind of flat fee, because money is also an issue in moving these people, either subsidized by the government or charity organizations. There are a lot of charity organizations that can work on this if we actually have our act together. If you do this, suddenly you have 50 ambulances in Lagos alone. This will be true for many other places. And more people are going to enter into that business and be able to make the ambulances available. Whether you're creating a dedicated stroke ambulance like we have, I don't know about that, because you need to have the passion. I'm very lucky to be supported by excellent people who understand that this dream has to come true. So I wouldn't have dedicated yet in Nigeria, but I'll have ambulance services that meet certain specifications, and I'll create a pool where people can easily call 24/7 hotline, and any of these hospitals can pick them, and then there will be protocols and standards how to move these patients. That's what I would do. I would also educate the people who drive these ambulances on some basic questions. It doesn't have to be the Cincinnati stroke score and the stroke scale. Develop something very, very simple. Can he talk? Can he not talk? Is he weak on one side? Is he not weak on one side? That's it. Don't give him anything to swallow. Period. Just some basic things. That's what I would do to develop that ambulance system. And then build on that. Once you are able to get that rudiments in place, then it's easy for you to start. Every year you modify, you make the stakes a little bit higher, and gradually higher, and gradually higher, and gradually higher. If, say, for instance, moving anybody in any part of Lagos, it will cost you, say, 50,000 naira or 30,000 naira. There are times you have to move somebody from point A to B, and it's really cost you 6,000. How much is an Uber, for instance? Ubers are 6,000, 10,000. Rarely you get 15,000 around Lagos. So this thing is practicable. Sometimes, but you have a flat fee. That means if you move long distance, the patient may lose money, but if it's short distance, they may gain money and, use and pay for distance. And then, of course, figure out a way to support them. I don't know. Maybe the true fuel subsidy should go to these people who are moving these people around, And then probably once a year or twice a year, have a national, whatever state, stroke ambulance, or in general ambulance drivers summit, and that is online, like what we're doing now. They get on the phone, and 30 minutes lecture on what you need to do and what you don't need to do, and maybe figure out an incentive to give to them to ensure they actually sit down and listen to it. There are a lot of young school leavers who can be able to be in charge of these services in various hospitals that are part of this consortium. That's how I would approach pre-hospital care for now. Believe it or not, we had a mobile stroke unit here, and because it wasn't really in use, the huge van that we spent a lot of money on broke down. There are a lot of efforts now to create. In fact, we are working with a Canadian university that is applying for funding to create what is called a low field MRI using open source technology. I'm very excited that if this works out, that it may change the paradigm of care. And the whole idea is that MRI is going to be mobile. It's very low field, but it can scan, get you what we call a diffusion weighted image that tells us, is there a stroke, is there no stroke? The pictures typically would not look great, but using artificial intelligence, they can optimize the imaging. So we applied for that grant with the Canadian University to see if we can get a grant. They can build it and then be able to have this in a lot of low resource countries. The good thing about that MRI is a permanent magnet. It's not subject to the problems you're going to have with a CT scan. It's very simple. You push the person, you get the quick imaging, then the artificial intelligence optimizes it, tells you, is there a stroke, is there no stroke? So we're working on that, and there are quite a lot of hospitals and organizations that are working on that too. So we see how that works. So there's a lot of future down the road, but so you have to get ready so that when these resources are available, it's easy, it falls on your laps immediately, and then you can go from there. Nigeria is not a lost story. We're not a lost cause. We have very intelligent people. I mean, many professors that are respected across the globe, So we're not a lost cause. We just have to put our heads together and have some sort of direction, little minute baby step direction. When you have a lot you want to accomplish in a unit time, it won't happen. When you do it by baby steps, you will probably be amazed where you will be in the next
That's
5 years.
Yeah, so we'll probably end with this question, Paul. How should Nigeria measure progress over the years? Like, should they use stroke registries? What outcomes, what dashboard should be used as a metric system for measuring, how we're doing with stroke care in Nigeria?
I think there are different metrics. We can use different things. It could be probably resources based. It could be processes. It could be outcomes. So in terms of mortality, I do think the first thing, the easier things, is to look at the resources we do have in terms of the manpower. How many stroke trained nurses we have in the next 5 years? How many neurologists do we have, in the next also 5 years? And we can also look at stroke units. How many stroke units also per state also do we have and then we can move beyond the stroke units and stroke centers to a comprehensive stroke center, as clearly explained. So if in the next 5 years we say, okay, our plan is to have a comprehensive stroke center in each 6 geopolitical zones, that will be very good progress, a way of measuring our progress. And another way to measure progress is mortality. There are a lot of things, significant stroke mortalities in Nigeria. So, if we do a study in the next 5 years and say, okay, our stroke mortality has reduced from 40% in a month to, we've halved it, that could be a measure of progress. So, I think those are the metrics we can use. And the good thing is that we're moving into the phase 2 of the Nigerian Stroke Registry, where we're actually calling other centers to be involved. We started the phase 1, the pilots of the Nigerian Stroke Registry back in October. We recruited up to 200 people. So we are moving into a larger phase. So once we have the data is very important to be able to measure progress. So I believe the Nigerian Stroke Registry is a very good database for us to be able to measure it. And so we need to set a very realistic also target also for us. And I think once we use those metrics, resources, processes, outcomes, and National Stroke Registry, we'll be able to easily measure our progress. I think as Professor Anyanwu has said, I think it's all about starting small. It's poco a poco. What is a low-hanging fruit? What can we do? What basic things? As simple as stroke nurses can alter stroke mortality. And I do think that those are the ways we need to look at things, measure things in a very slow, progressive way, then reiterate and try to improve over time. And one thing I also want to mention also before I give is we need stroke heroes. We need more people like Professor Anyanwu, not just being abroad doing great things. Africa is our home. Nigeria, sincerely, no matter how long you spend in countries, there's a whole lot of ways you'll be measured. We do know about this. And there's no place, I'm sure Professor Anyanwu would, that there's no place like home. Hopefully in the next few years, I'm thinking I would also come back to Nigeria to support. But we need stroke heroes like Professor Anyanwu. We need people to come together and build the nation. And not everybody would come to Nigeria. I said, we can influence things through what you're doing. Also, IB by this was fantastic. Also, so when we join hands in hands, do something small, also collaborate together, we will change things. And hopefully in the next 5 years, I believe that Nigeria stroke care will be quite different, even to where it is now.
No, thank you for that. And I think I did say that was the last question, but I think I want to talk to anyone listening who either has had a stroke person in their family or they've experienced stroke before. Just what would you say to someone who has someone who's had a stroke in their lives and how they navigate the future? So to both of you, I want to hear from both of you on that question. Like, what would you say to somebody who's looking after a family member who's had a stroke? Like, how do they navigate the future?
In Nigeria, I don't know, but I'll tell you what is possible and what we're trying to do. We know that there's actually a lady in Anambra State who's doing very well that has a network of stroke survivors. And you need to figure out how to look for help because we talk about the stroke patients. We're not talking about their families. And I'm happy that you raised up that issue. It's life altering. dealing with a stroke patient, life altering. Sometimes people don't even know what to do or what to believe. But if you have a stroke survivors group, it makes a lot of difference. We know this already. At Regions, we just recently, just about last week, hired an educator who's going to start that slowly. I suspect there are a lot of online groups, maybe not based in Nigeria, that people might be able to join because there are a lot of information out there, a lot of not quite true, a lot of myths around stroke. But I think that's a good question. We have to start forming more of stroke survivors networks and groups and WhatsApp groups that can be moderated by people who know what they're doing. Because you still go through the streets of, at least I'll tell you, we're here in public address system. We treat stroke, we treat with stem cell, we do this, we treat gonorrhea, we treat we treat stroke, we treat cancer, and people sometimes don't know what to believe. So I think creating stroke survivors networks and groups will make a lot of difference, and we're trying to do that at Regions. And I encourage my colleagues out there, especially those in public hospitals, that when we launch this, we're going to spread it around. But Paula will tell you about it as well. Let's get a lot more people to join and become moderators in these groups. Provide patients and their relatives and survivors the accurate information as to what is going on and how they can get help even from their homes.
Yeah, I think for me, what I do tell my patients is that stroke journey is a marathon. It's not a 100-meter sprint. That's the most important thing. So as a caregiver for a stroke patient, understand that it's a marathon race, and so it's very important they have a resilience, in terms of making sure that the family with stroke is supported. It's very important. In terms of rehabilitation and in terms of making sure that they have access to also therapists, and also to make sure that they are taking their medications as a secondary stroke prevention. After you've had a stroke, there's like an increased risk, like close to 30% in a recurrent stroke in the next 5 years. So it's very important to use also those medications. Yeah. But in Nigeria, it's we are still a bit behind in terms of supporting. But there are a little bit of snippet of stroke support, group, like the Stroke Action in Nigeria. Dr. Melifon does a lot of
Yes, Rita Melifon, that was the name I was thinking about. Rita.
She's brilliant, she's got a PhD in nursing, and she's really doing a lot of stroke advocacy. So I think that we do have some of those stroke charity organizations, and I'm sure if they're able to contact, you, I'm sure we're able to give them probably the numbers and the resources. And also, they should also have hope. Hope is very important. After a stroke, it's a very devastating experience. It knocks your confidence, it knocks your mobility. Some people are out of work, but hope is very important. Hope in terms of Nigeria stroke care is going to improve, and that's the hope that we do it. Yeah, thank you.
Yeah, and that's a wonderful note to end on. Hope. There is hope in terms of stroke care in Nigeria, as you've heard on this episode. I'll summarize and say that we've talked about capacity building in terms of human capital, in terms of financial capital, in terms of systems capital. So building the system. And we've talked about what families can do to help themselves, what the government can do to help themselves, and the governance around stroke, both in Nigeria and across the African continent. So we hope you've enjoyed listening, and hope to see you soon. Thank you very much, everybody.
Thank you.
Let me just stop that.